Hi, I'm Ann Greiner, President and CEO of the Primary Care Collaborative. And for those who may not know the Primary Care Collaborative, we convene stakeholders from across the entire healthcare landscape, really those that are committed to improving the nation's health by strengthening primary care. I'm thrilled to welcome you to today's discussion, the evidence behind whole person care. Before we get started, I'd like you to know that this is being recorded and it will be made available within 48 hours on our website. When you go to our website, you will see webinars from the past. So please feel free to review them and share them with others. We'll also be taking questions throughout the entire period of the webinar, but we'll answer them at the end. You'll find a button at the bottom of your screen where you can put those questions in, and members of the team will be dropping in resources throughout the webinar. We're really committed to providing the highest quality educational sessions that we can, and so we ask that you fill out the survey when you receive it. It will be after the webinar. And in a moment, I will turn the moderation over to Yael Lehman, who's the Interim Executive Director of Families USA. But before we get started, I wanted to acquaint you all with a project that we've just started focused on whole person health. It's a new initiative. It's jointly funded by the Ardmore Institute of Health and the Healing Works Foundation. And what it does is aim to promote a deeper appreciation of health, whole health and lifestyle medicine concepts and the evidence behind them. We also want to assess how we, the primary care community, can collectively move these concepts into mainstream practice. Part of our work establishes a work group to advise the PCC, and we've convened a really remarkable group of leaders, 14 members from clinicians and health plans to employers and consumers. As part of this work, we're hosting a 3-part webinar series, and this is the first of the 3. The second webinar will be focused on the business case. How does investing in whole person health and lifestyle medicine impact overall costs? So you won't hear a lot of that discussion today. That will be reserved really for the second webinar. Our third session will be hosted this fall, and it's going to be focused on whole person care and chronic disease. So please stay tuned for those webinars. We hope that you join us in the future. And there is the list of our advisors to this work. As you can see, they are experts in their own rights, and they are bring incredibly diverse perspectives. Now let me turn the dais, if you will, over to Yael Lehman. As I mentioned earlier, she's Interim Executive Director of Families USA. Families is a national nonpartisan voice for healthcare consumers. We work with them very closely and are honored to have Yael here today with us. Families is dedicated to achieving high-quality, affordable healthcare and improved health for all. She was previously Executive Director of the Mid-Atlantic region for the Common Market, as well as President and CEO of the Food Trust, which successfully advocated for the Health Food Financing Initiative. She's a fellow of the Aspen Institute's Health Innovators Fellowship and really a leader on issues of food access. Thank you so much for joining us today, and we really look forward to the webinar.
Thank you, Anne. And thank you to everybody at the Primary Care Collaborative for inviting me to moderate today's discussion on whole person care. It's going to be a great discussion. We're going to talk about how do we get beyond diagnoses and medications and procedures and reorient the healthcare system to deliver health. Before we jump into the discussion, I'm going to briefly introduce you to our rockstar panelists. Shauna Hudson is a Senior Associate Dean for Population Health Research at Rutgers Robert Wood Johnson Medical School. She's a medical sociologist specializing in primary care research and has served on multiple National Academies of Sciences, Engineering, and Medicine committees, including on implementing high-quality primary care and on transforming healthcare to create whole health. Darshan Mehta is an assistant professor in medicine and psychiatry at Harvard Medical School. He is the medical director of the Benson Henry Institute for Mind-Body Medicine at MGH and the Osher Center at Brigham and Women's Hospital and Harvard Medical School. Dr. Mehta's educational and research interests include complementary and integrative medical therapies and mind-body educational interventions in health professions training. And finally, the very fabulous Beth Frades is a physiatrist, I just learned how to pronounce that today, and a health and wellness coach who serves as president of the American College of Lifestyle Medicine, an associate clinical professor at Harvard Medical School. She is considered a pioneer in lifestyle medicine and has developed several lifestyle medicine curricula. Okay, so we're going to get started. It's great to see you all, and I'm so happy you're here today to have this discussion on whole person care. I think a great beginning is just, let's talk about the definition. What are we talking about when we talk about whole person care? What does the term whole health mean? And what does whole person primary care encompass? The National Academies of Sciences, Engineering, and Medicine released a report last year on this very topic, and Dr. Hudson, you served on that committee. And so we'd love to hear how the committee defined whole health and whole health care. I know also you're a researcher and you've worked with cancer survivors and you've heard from patients about what they want and what they need and how important relationship building is as part of whole person care. But I'll turn it over to you, Dr. Hudson, to start us off on how we define this whole person care.
Thanks so much, Yael. So the committee actually thought about this very holistically, and so came to a consensus around thinking of whole health as being about physical, behavioral, spiritual, and socioeconomic, meaning like your economic well-being. So the goal of it is really to think about individual families and communities and how they actually define those concepts, as opposed to a more biomedical sort of framing on it, which is really thinking about it from the perspective of our healthcare teams or our clinicians and others sort of diagnosing. So I think that's one of the major sort of shifts in terms of the definition in thinking about whole health. Is it's really about how individuals and their communities think about those different aspects. I think if we think about what is whole health care, then that's actually, the committee has really defined it as a team-based approach. And it's really focused around what we call trusting longitudinal relationships. So making sure that there are relationships between patients, their families, their communities, and their healthcare team. And it's really that relationship's got to align around their issues around what their personal life missions are, what their aspirations are, and really what their goals are. So just to sort of tie it up, it's a very comprehensive report, but there are 5 sort of pillars that came out of the report that we looked at and said, these are the major elements of what whole health is. And so the first one is that it's got to be people or person centered. The second one is that it's really thinking comprehensively and holistically about an individual. That it actually deals with root causes, so that it's upstream focused in thinking about how that's going to impact and ripple throughout the life course, and that it's equitable and that it's also accountable. So we're making sure that people have access to care regardless of where they're at. And then the final piece of a whole health approach is really making sure that, again, it's team-based. So it's also incorporating the patients as part of their healthcare teams and as decision makers on it. So those are the key aspects to it. I think it's really relationship focused. It's about the person as part of the team and a team-based approach to care. So I'll hand it over to the others on that panel to think about some other things to add to it.
That's great. Dr. Mehta, did you want to add to your thoughts on the definition?
Yeah, I mean, I think from just a big concept perspective, it's a real paradigm shift from thinking about, a disease-centered approach into truly what is, we begin, especially as a health profession, to think about what does optimal health and well-being mean. And I think, again, from a pedagogical perspective, we are not taught that way. We're taught that the person is ill, and that's our starting point. And you are, and so you're fixing the illness. Oftentimes is how we are. Many of us in the health professions are educated that way. But this is really a shift into thinking about, okay, actually the person starts off well, and how do we keep them well? And I think that's a big paradigm shift. It's going to have, I mean, this type of report has major implications on not just how we deliver care, but how we also educate the next generation of health professions across all the different health professions, including obviously physicians, nurses, allied health professionals, but also as we begin to think about complementary and integrative healthcare practitioners as well.
Oh, that's beautiful. I love that we start off with thinking the person started off well, and how do we keep them well, as opposed to this person is ill. That's beautiful. Dr. Frades, how about you?
Terrific. Yeah. And in that paradigm shift, I think a key piece is it's not necessarily what's the matter with the patient, it's what matters to the patient. I think that's a key piece of that paradigm shift too. And in the definition of whole health, we discussed how it promotes resilience, prevents disease, and restores health. We can also talk about chronic disease reversal and putting chronic disease into remission with lifestyle medicine. We know that lifestyle medicine provides the pillars that really support whole health, with the routine physical activity, whole food, plant predominant nutrition, restorative sleep, stress management, positive social connection, and avoidance of risky substances. These 6 pillars, when prescribed appropriately, we know they have been shown to put chronic conditions like diabetes and hypertension into remission. And I like the talk of root cause and the upstream focus of whole health. I think that's key. We know that inflammation is associated with so many of these chronic conditions like heart disease, obesity, diabetes, and even depression. And we know that when we eat well, a whole food predominant diet, a plant-based, we can really put inflammation to rest. And then routine exercise, stress reduction, and sleep can also help lower this inflammation. So really, by looking upstream, we're really looking to tackle lifestyle behaviors. And if you remember our seminal landmark study by Mockdad and colleagues, the actual causes of death that was published 2 decades ago in JAMA in 2004, where they talked about poor diet, physical inactivity, alcohol as being the actual causes of death. Of course, coronary artery disease continues to be our #1 disease that's killing us, but what are the behaviors upstream, like whole health is talking about? And in 2018, when Mockdad and colleagues updated their data, they warned poor diet, high BMI, high fasting plasma glucose, alcohol use disorders, drug use disorders were all contributing to our death rate and disability rate. And they used that journal article as a call for us to start to address lifestyle factors. I'm so happy this webinar on whole health is here today. It's so timely. And together, I really feel like we can get to the root causes of disease and disability. So I'm delighted to be part of this.
Thanks. That's awesome. Well, actually, that's a perfect segue to my next question, which is about the evidence. So you've just now been talking about some of the evidence and some of the journal articles that you've referenced just now. But at a high level, what does the research show us about this approach? How does it affect patient outcome and experience? And I'll kick it to you, Dr. Frades, again, about what does the evidence tell us about addressing lifestyle changes? You just mentioned that we can reverse things like diabetes, but I'll kick it back to you on that one.
Terrific. I love this. I love talking about the evidence and the science, as well as the art of the therapeutic alliance. But let's get to the evidence that's mounting on the power of these 6 pillars. And, this is part of the reason why there's increased numbers of lifestyle medicine board certified physicians and professionals, and it continues to grow because we know that we must address the upstream causes, these root causes. And in fact, the U.S. Preventive Services Task Force has grade A and B recommendations for lifestyle behavioral counseling for a variety of conditions. And as you know, if it's grade A, That means it recommends the service because there's high certainty that the net benefit is substantial. And we also have grade B. And that is for the recommendation, the service is there at grade B because there's high certainty that the net benefit is moderate, or there's moderate certainty that the net benefit is moderate to substantial. So these are grade A and grade B recommendations. So for our grade A recommendations, the use of lifestyle behavioral counseling is suggested and recommended and it should be provided for those with tobacco smoking and cessation in adults, including pregnant people. Grade B recommendations for the use of lifestyle behavioral counseling for cardiovascular disease prevention in adults with cardiovascular risk factors, healthy weight and weight gain in pregnancy, weight loss to prevent obesity-related morbidity and mortality in adults, obesity in children and adolescents, prediabetes and type 2 diabetes, tobacco use prevention in children and adolescents, perinatal depression for preventive intervention, unhealthy alcohol use in adolescents and adults, unhealthy drug use, and lastly, in falls prevention for community dwelling older adults. It's a grade B. So that's coming from numerous studies that demonstrate the power of lifestyle to achieve a range of health benefits, from disease risk reduction, to disease remission. Specifically, there are documented improvements in outcomes for high blood pressure, blood lipids, BMI, heart disease, mental health and depression, and a reduced risk of Alzheimer's disease, reversal of coronary artery disease, and there are studies documenting remission of type 2 diabetes and non-alcoholic fatty liver disease following lifestyle intervention. These studies are from 1998 to 2023, and they are mounting. Some of you know these key studies: intensive lifestyle changes for reversal of coronary heart disease in JAMA, by Dean Ornish and colleagues in 1998, seminal study. The Look Ahead Research Group, Cardiovascular Effects of Intensive Lifestyle Intervention in Type 2 Diabetes, New England Journal of Medicine, 2014. Another 2014, the Complete Health Improvement, or CHIP program for history, evaluation, and outcomes in diabetes and lifestyle medicine. And then Mind Diet Slows Cognitive Decline with Aging. That was 2015 in Alzheimer's dementia. The Broad study, some of you are familiar with this one, randomized controlled trial using whole food plant-based diet in the community for obesity, ischemic heart disease, or diabetes in nutrient and diabetes. That was 2017. In terms of weight, effective weight change and lifestyle modifications on the development or remission of non-alcoholic fatty liver disease, a sex-specific analysis from 2020. Then we go to 2022 with the DIRECT trial, experiences of healthcare professionals delivering the diabetes remission clinical trial, familiar with that one, and diabetes medicine. And then lastly, two in 2023, looking at remission of type 2 diabetes after treatment with a high fiber, low fat, plant predominant diet intervention. This was a case series in the American Journal of Lifestyle Medicine. And lastly, efficacy of a multimodal lifestyle intervention, which is the LIFT project for improving the mental health of individuals with an affective mood disorder living in South Africa, published in Frontier Psychology. Now, the research in the 6 pillars of lifestyle medicine is ongoing. I just named some landmark ones for you to evaluate. There's also more and more research on the way certified lifestyle medicine clinicians counsel patients around behavior change with that coach approach. The importance of collaborating, negotiating to help build the therapeutic alliance, to provide relationship-centered care, and to create that trusted longitudinal relationship that promotes resilience. The counseling sessions in lifestyle medicine help align a person's health goals with their life mission, aspiration, and purpose. And you're going to see more and more research in this.
Thanks, Dr. Frades. That's awesome. Yeah, it's an important, this part about the relationship and the coaching, and we appreciate hearing directly about the wide amount of evidence and all that's been published on the issue. I'm going to turn it to Dr. Mehta. I know, and I know, Dr. Frades, you've done coaching and worked with groups and people who suffered strokes and all. In addition, in this evidence discussion. It's also interesting to hear about any of the groups that you've worked with or as you're training physicians, in addition to any of the studies that have been published. But Dr. Mehta, tell us some of your thoughts.
Yeah, no, I think this is an important element. This is actually, again, group-based work, and we do a lot of it, particularly in mind-body medicine and integrative health. Interprofessional teams, group-based work where sort of multiple patients come together in a group, whether it is around the context of a shared illness, or it's in the context of a shared sort of goal. There's sort of different ways to think of it, of group-based work. But this is this concept actually has been around for decades, but it's really taken off, particularly in the last decade, in part because one is it's a better use of resource. I think we have one person being able to serve 10 or whatever, 6, 8, 10, 12 people at a given point in time. But the other more, I think, important piece is that this type of work really I think benefits from the social support networks that are created as a part of the experience. And so by nature, most of us human beings, we enjoy or we desire being in the company of others. And I think as we learned from the pandemic, the social isolation that was forced upon it we are still bearing the consequences of that. And I think, again, some of this group-based work is essential. I think more, there are now many more innovations. Obviously, we have a lot of telehealth practices that support this, which has actually been a key catalytic moment. Again, the pandemic sort of catalyzed the whole telehealth movement in a way that we never could have expected. And I think it's here to stay. And we've learned that this can actually help, again, create a sense of community that is important. And I just want to add one last thing, which is, while the research has been much of the research has been disease focused, where the growth opportunity here in whole person health is, what does it mean, again, to be healthy? We always define illness and what's wrong with people. We actually don't have very good definitions of what it means to be healthy yet. And I think this is an important growth opportunity, both, again, from an educational perspective, which is where I live most of the time in medical and health education, but also from, I think, from a research perspective, what does optimal health mean? And again, it means different things for different people. And how do we begin to define that, study it, evaluate? So.
Wonderful. Dr. Hudson, did you want to chime in on this one?
I did. So, and it was interesting just sort of listening to the different perspectives because they're very holistic. And so what I wanted to bring in was thinking about this from the perspective of, all of the different components of whole health. There's a significant evidence base to all of the different pieces. One of the things that strikes me about it is really sort of the issues around health equity and how do we address sort of access to care. And so when people have whole health or access to whole health, we've seen the increased access reduces their usage of the emergency room. We have fewer hospitalizations, that better relationship with either their primary care, their specialty care, but this holistic sort of perspective really does increase outcomes. I think there's better evidence in terms of both patient-reported outcomes and patient care. And we have fewer studies that are focused around sort of very clinical outcomes, but it's an area that I think is really interesting and ripe, as Dr. Mehta was saying, for really reconceptualizing how do we think about what is healthy and how do we then measure it.
Well, that's a perfect. Let's take that thread actually that Dr. Hudson just took us to. We want to encourage healthy lifestyle choices. We also want to acknowledge that not everybody has the same choices in front of them, and that access can be different for different people. And when we're talking about a whole health approach, I'll kick this to Dr. Mehta. I don't know, to start us off, but what do outcomes look like for different historically marginalized groups, for example, and how important is access in this conversation?
Well, I mean, access is critically important. I mean, there's no question that having access to healthcare is important. And we are in this crisis moment that has been well documented, especially in primary care. where many primary care providers, especially especially physicians, are leaving the profession for a whole host of reasons, and I think that is creating a true stress on the healthcare system in a way that we actually had not anticipated. I mean, I think something just has catalyzed in these, again, particularly I can speak to our system here in Boston. It's a difficult time, and that's the reality. With that said, it turns out access is not the only thing, though. And I'll just use our own city as an example. It's pretty, again, well documented that in the city of Boston, and it's sort of the villages or nooks of Boston, we don't actually have an issue of access to healthcare in some ways. We have four quaternary care hospitals that are within 3-mile radius of each other, top-notch, institutions. And if you go to the neighborhoods of Roxbury versus Jamaica Plain versus Back Bay, so Back Bay is a highly affluent, mainly white families who live, and individuals of privilege who live in Back Bay. Jamaica Plain is sort of now this newer sort of bougier area that used to be less so, and now it's becoming more so. And then Roxbury is traditionally marginalized, mainly BIPOC communities. They all are within 2 miles of each other, and the life expectancy difference is 65 years roughly, and I may be getting my statistics wrong, but I'm in the right sort of, to 85 years. We have a 20-year lifespan difference between these communities that are within, you can make an equilateral triangle. And the thing is, it's not about access. They all have access to the hospitals here. Everyone, I mean, Massachusetts was the first state to have access to healthcare for everyone as a right. It was the first state in the country to do that. So again, this is it brings to issue, like there are other things that we have to think about. Neighborhood effects, again, access to healthy eating spaces you can eat, sidewalks, bike lanes. You can see, like, this is they're very distinct areas where you can see, oh wow, they're well resourced, and you just literally walk a few blocks and, oh, not so well resourced areas. And so I think this is very much an equity issue, and that very much has health consequences that have been directly attributed to this. Not to mention, there are other reasons too, but I'm just using this as an example.
That's such an important point, that this is beyond just access to a wonderful hospital. This is also about, what are the resources in your neighborhood? Do you have access to healthy food? Are you able to walk around the neighborhood? Are you safe in the neighborhood? Do you have access to transportation? Do you have a job? Do you have good banking in the neighborhood? All those other factors matter as well. All right, well, let's move on to person-centered care. What do we know about the evidence behind taking a person-centered approach to care? I'll start with Dr. Hudson on this one. Do individuals and their families experience care differently, and does it ultimately affect their health?
Yeah, so I mean, if we think about what person-centered care is, it's really thinking about all of those different things that make us who we are. So our individual experiences, thinking about it in the context of our families, communities, and those other pieces, our relationships, and basically thinking about our clinicians as people. And so the evidence in the whole health report is that, if we think about these pieces, that it is very important. Actually, if you go back to the question that we had, there's sort of linkages between these two pieces. There were some really interesting case studies that were in the report that were around the VA, also the Mary Center and the NUCA group. And some of the things that were really interesting in terms of outcomes for some of our underserved populations were really around the social supports that were happening within those particular settings. So it wasn't just about the healthcare within sort of the clinic walls, but really making sure that it was sort of nested within the community and that there were supports and things that were going on. So support groups, a bunch of different things that were occurring within those settings that both were outward facing into the community, but then really brought the community into the groups. And so I think in terms of thinking about outcomes for different populations and how do we get them to places where we want to actually see them and see equity increasing, we really need to be thinking more about some of these like bright spots and models of how you actually do healthcare within the community and bring the community in as part of that.
That's beautiful. Dr. Freitas, I know you've worked with a lot of groups and do a lot of counseling. And I know this part around social supports and thinking about beyond the walls of whichever medical establishment we're in right now. How do we integrate the community, and how do we feel like that we're surrounded by more than just the medical professionals to help us through to be healthier? What are your thoughts on that?
Yeah, I love this discussion so much, and I'm going to weave in a couple threads from the the previous questions. So the group visits that you talk about and that I love to do and piloted in 2012 at Spalding with the stroke care survivors, I like to actually, and I have since the beginning, invite a loved one. So we have the stroke survivor and a loved one. Usually it's a spouse, sometimes it's a mother, sometimes it's a son, but usually it's a spouse, a partner, a loved one who comes along in the group visit. Whereas Darshan said, we will have 12, maybe 15 in the room and talk about the upstream root causes of disease. And what's fascinating is when you get this group together, they should start sharing resources that I don't know about. Like at the YMCA in one of the neighborhoods in Boston, they were offering a special program for stroke survivors who were weak on one side. I actually didn't know about that program, but because I was running a group, the group members were able to share with each other and create these social connections and start using the community more. Because when we're in person, this is different than telemedicine where people could be in different countries, but when we're in person and we're centered around different communities, we learn together in these group visits. And during these group visits, we also learn about the patient in a different way as the provider. You are learning a lot more about their neighborhood, about what is available to them, about what their kitchen setup may be, because you have time in these group visits. Usually they're 90 minutes to 2 hours. So as you go through this process in the 6 or 12-week session of a group visit, you can really enhance that therapeutic alliance, that patient-centered model, and that longitudinal experience so that there's trust built. People get vulnerable in these sessions and really honest, and they can really make progress during these sessions. And also during these sessions, you can share resources. We talked about equity and living on a budget, which is real. As Darshan said, here in Boston, I can have people in all different socioeconomic areas. And so what we learn in these group visits is that we can share, for example, eating on a budget. We have this at the American College of Lifestyle Medicine. It's free. There's tools available. Eating on a budget and the power of beans, the importance of utilizing frozen fruits and vegetables. Even if you are in a community that can provide you with the latest crops that are seasonal, sometimes you actually go to your frozen broccoli. And then normalizing the use of frozen fruits and vegetables is really powerful, because this is usually available, or it's more available than the seasonal products. So I think these group visits that combine a lot of different people and allow us to really learn about the patients are key for us moving forward with whole health.
I love that. I know just a personal story. I have a close family member with diabetes, and she felt very, very alone. Like we all do many of us have had health conditions over our life, very alone. And when she was able to participate in a group of others who were experiencing the same thing, suddenly, first of all, like you mentioned, trust. When someone else is experiencing the same condition you are, you trust that person immediately. You feel understood, you feel seen, you're like, oh, and so there's this beautiful thing that can happen when you're sharing resources, as you pointed out, feeling less alone, but then also trusting and learning about other things that might help you to be better, to feel better. All right, well, one last question I'll pose to all of you before we turn it over to the Q&A, because I'm sure there's a lot of folks here chomping at the bit to ask you all questions, and I'm taking all your time. But one more. And this one I'll start with Dr. Mehta on the clinician experience. How does taking a whole health approach to care impact the people delivering care? Are there studies that show any positive benefits on things like burnout and satisfaction for care teams?
Yeah, I mean, I think, again, this is a very much a new and evolving concept, and research is very much evolving in this arena. We have certainly a lot of experience from our VA colleagues who have been working in the sort of in whole health, and they've certainly shown that this type of mechanism has been both important for the clinical experience as well as the patient experience, and they've been able to deploy this across all the VA hospitals in the country, but it's still as a work in that is continuously being refined and improved, and but that is certainly one model where we've seen where there is certainly clinician satisfaction associated being part of the whole health team. I do know that, again, many people, there are competing pressures here for a lot of clinicians between what is defined as productivity and an administrative burden versus working in a team-based approach. And I think some of the factors that have to be considered when you're thinking about what improves the clinician experience is that one is, does this help reduce the burden that one person feels in the care of the patient? Because it's oftentimes a team-based approach, there's a shared experience in the care of the patient or the patient and their families, that actually allows not one person to shoulder all the burden of that individual's or that family's concern. And that's part of I think, one piece. And that includes administrative burden, right? And things about documentation. There are now new innovations on how do you actually document in a team-based note rather than document sort of single notes that are, and you see this long list of notes in a chart, and you're like, okay, which one do I read first? And that's often difficult, especially with individuals who have multiple chronic medical conditions. So I think there are a lot of new innovations. I would be remiss if I didn't talk about the role that artificial intelligence and sort of large language processing will have a role in the delivery of care. And I think that's going to be an important part of how we think about, again, thinking about the concept of the team and how, again, technology can help augment the notion of the team.
Oh, wow. I hadn't thought about the AI factor. I know it's impacting every single thing literally in our entire lives, but no, that's really interesting to think about. Dr. Hudson, did you have any thoughts around this question?
Yeah, so I mean, it's been interesting thinking about the experience of clinicians in whole health. And so I think one of the areas that I think we can explore in this is really around how do you build the system around these teams, because again, our systems haven't really been set up to be able to document the work of a team. And so I think that's going to be an area as we sort of think about how do we make this even better, that building those systems around it is going to be really, really important. So thinking about how do we reorganize our practices, how do we do rooming, how do we bring patients in, group visits, all the other things that we've sort of talked about earlier on, making those all part of our common day-to-day work as opposed to exceptional things that we do when we have an opportunity. So I think there's some great opportunities. And for some of the examples that we had in the report, there were some really interesting vignettes around how the clinicians were able to address issues like burnout and to address that within the context, because you're sort of getting fed because you're working with different populations and being able to actually have those existing relationships. So a lot of it was really around sort of the relationship building and thinking about how do we get systems that help us to do that.
That's
Oh.
so interesting, isn't it? I'll go to, and Dr. Frades, I'll go to you next, definitely. But I just had a quick thought, which is this, as we're talking about relationship building, how it goes both ways, as Dr. Hudson just pointed out. It's for the patient who's there, it's so critical, but it also could help the physician as well to feel less burnout, because the connection happens both ways. Dr. Frades, how about you?
Yeah, that's a great point. I love that point. And also, I just bring it back to the group visits. I truly love doing these. And there has been data around patient satisfaction with group visits, as well as physician satisfaction with group visits, and increasing satisfaction, decreasing burnout, delivering whole health by lifestyle medicine practitioners. There was a recent study, colleagues of mine, I think some are on the line, Kathy Pollard and our President-elect Padmaja Patel actually, and a group did this study showing that lifestyle medicine practitioners implementing greater proportion of lifestyle medicine in their clinical experience actually had less burnout. So we're really starting to look at this. There was another study people may be interested in that looked at physician burnout. It was in the American Journal of Lifestyle Medicine 2020 by Jim Rippey and Gia Merlot, and they really dove deeply into this, how lifestyle medicine and the use of lifestyle medicine could help with physician burnout. I think it's going to be a rich area of study, and together we'll learn more.
Okay, now we're going to go to the Q&A, and I'm sure none of you will be surprised to hear there's a ton of questions. Just so the audience knows, also, we'll do Q&A for probably about 10 minutes or so. We'll take it close to the end of the hour. Then I am going to have each of our wonderful panelists just give a few closing thoughts before I kick it back to Anne. Okay, so there's a lot of questions. I'm going to start with maybe it's the AI discussion that made me kick it to this question, but somebody's asking, how do we do this with a virtual care experience? What does whole person care look like in the virtual care world? If I don't know, you can feel free to unmute yourself and jump in.
Yeah, I mean, I don't think, again, it's building of relationships, is I think transcends I mean, obviously there's something sort of having the physical connection, and I don't want to say it can replace it, but we are demonstrating that effective models of virtual care, there are effective models of virtual care. It actually grants more access because, again, I'm going to just use my own city of Boston as an example. At Mass General, I mean, for someone to schlep in the middle of a very busy intersection and then think about parking and this, and it's a very ineffective and inefficient use of time and resource. And if certain types of care, I mean, again, some care is required in person, some care we can actually be very effective and actually have someone actually be very present in the encounter because they're not worried about where they're going to park and all these other factors that often, and again, this disproportionately affects individuals from marginalized communities more. And again, I think we often, I think, especially as a healthcare system, forget about that who is this affecting more? It ends up affecting the people who actually would actually need more access to the healthcare system in a more regular basis.
That's great. Yeah, so telehealth, this can definitely work in a telehealth. What I'm hearing you say is this definitely works in a telehealth format. And in fact, in some ways, we're more at ease. We're not rushing around. Okay, I have another question for all of you. Given the paradigm shift, what do you see happening with uptake of this approach to healthcare? Are health plans or carriers paying for it, covering it? Are primary care practices adopting this team approach to care?
So I'll start out with that. So I think that there are places, and one of the things that we found in the report is that there are places that are implementing different pieces of it. And so, yes, we've seen that there are some places that are doing lots of things, but nobody's been doing whole health comprehensively all the way across. So I think that in this case, as we think about whole health, we're really going to need to do some advocacy with our payers so that they better understand not only the benefit to it, but then how do we actually get those benefits? So thinking about group visits, thinking about are all of the team members being reimbursed? Like there are some major systemic issues in terms of how we are dealing with care in general. And that came out in the Implementing High Quality Primary Care report as well as this. But I think that we're going to need to think about how do we bundle those together around these discussions, because it's very clear that whole health is a really relationship-oriented concept, but we're working in a paradigm that doesn't actually reward that relationship, and in fact is more about how many work RVUs can you get in and how quickly can you get them done. So we also need to think about outside of that context, how do we actually start to move the ball around those issues as well, so that we have a system that actually supports being able to do.
Okay. Yeah, I hear that. Coming from Families USA, we love advocacy. It sounds like this is an advocacy issue potentially.
Right. Yes.
Dr. Frades, or did
Oh.
you have a thought? Mhm.
I was just going to say, building on that, this is one of our top priorities. So with the American College of Lifestyle Medicine, every 3 years we meet and we say, what are our strategic priorities? What does the world need now? And our number one is implementable, reimbursable models, scalable models for delivering this type of whole person healthcare through lifestyle medicine. That's our number one priority, is trying to answer this very question. So any advocacy we can do and research we can do in this area will be wonderful.
Oh, good. And I'm sure that PCC is right here for it too. All right, Dr. Mehta, any thoughts?
No, I mean, I think my esteemed colleagues have said. I mean, I think this is again an amazing opportunity to think about. There again, paradigm shifts, not just in implementation and delivery of care, but also how we educate providers around these concepts. And I think education is going to be key. I think I see a question in the Q&A that was like, well, how do we educate? I mean, how do we change the paradigm so people start thinking this way in team-based care? And I think to me, how does dentist talk to physician? And I think again, in integrative health, I can say in that sort of domain, we do sort of think about that critically more often, especially at my own center, at the Osher Center for Integrative Health, where the acupuncturist has to be able to communicate to the physician, just as a chiropractor has to be able to talk to the massage therapist, and then across system to the spinal surgeon and stuff. So I think that requires a rethinking of our education and how we educate each other. Again, how we are educated.
Got it. So there's an advocacy piece and there's an education piece. All right, how about this one? Okay, I like this one. I mean, I like all of them, but I'm hopeful the discussion can touch on best practices for engaging patients. How can the team, team is in quotes, improve the mindset of people to want to change their behaviors for better health? So what are some best practices for engaging patients, and how can the team help change their mindset? Dr. Frades?
I love this one just because I trained in health and wellness coaching in 2008, and I've been really working on this myself and trying to help others to work on it and learn and grow. It's a process, but really it involves motivational interviewing. A lot of people may be familiar with that, right? It's actually doing less talking and doing more listening, asking open-ended questions, using affirmations, reflections, and summaries, hoping that the patient will see the value of change, helping to evoke change talk from the patient, not from you telling them what to do and how to change, but asking these open-ended questions that invite them to consider the positives of change. And what I found when I started 2008, utilizing this type of approach where you're collaborating and negotiating with the patient more than demanding, telling, advising, maybe threatening the patient. It's actually a lot more fun when you say, what would life be like if you did quit smoking? Instead of, you need to quit smoking, you're going to get a heart attack, you're going to get cancer. And then suddenly you're asking them to see their life, their world. And they start saying, I'd have a lot more money. I'd stop sneaking around. I wouldn't have to change my clothes all the time. I could visit my grandchildren. They start telling you all the reasons for change. And I think this is also partly why there's so much physician satisfaction with this, because it's much more fun to counsel when you're using this collaboration, negotiation, patient-centric, relationship-centric, whole health type of approach.
That's
And
wonderful. I love, oh, yeah, feel free
Yeah.
to just Dr. Hudson, go for it.
I was also going to add that I think normalizing a team-based approach is really important for patients, because many patients come in thinking about the experiences that their parents had and others. And so they're not familiar with the team-based approach. And so it's always about, well, what does my doctor say? What did my doctor say? So normalizing that there's a team here. You're going to be hearing from multiple people. These people are all part of this. And then actually like bringing them in so that it's not foreign that you're getting a phone call from somebody who's not the doctor, because you've already been sort of told as you're going through your experience that this is what we do in this setting, and this is how we care for you and how we build the relationship, so that if the doctor's not available when you come in for the next issue, there's somebody else here who actually knows who you are and can help with that. So I think doing that normalizing talk, and again, I think it's Beth said, it really goes back to some motivational interviewing, but really thinking about it in the context of setting up, what does that context of care look like, and health look like within our settings.
I
Got
love
it. Yeah, go for it.
I just love that so much. And I wanted to share, I love the warm handoff. So you'll be meeting with the registered dietitian, Julie, who works so closely with people on food. And you'll be working with the fitness specialist, or you'll be working with the health coach, and you give them the name, who works so close, and you describe what they do. I think that warm handoff, showing that they're part of the team, just like you said, is really critical.
That's great. So we start off by, first of all, listening, collaborating, and emotional interviewing. That's the first time I've heard that term. I love that. But actually giving them more open-ended questions and hearing from them. And then this part around normalizing the approach and making sure that folks are familiar with, what are we doing here? How is it different, and why it's better, and how a team-based approach means that you're going to get extra support. Okay, let's do one more question, and I think we have time for one more here, and then I'll let you guys close off with a few final thoughts. Let's see, how about maybe this is about terms and definitions again. So maybe I'll start with Dr. Hudson if you want to try to go for this one to start us off. I recently heard the term, quote, narrative health. Can one of the panelists provide some definitions and comment on what the relationship is between narrative, whole person, and relationship-based care?
You picked the wrong panelist to start with. So, I mean, I've heard of narrative, but I am not familiar with narrative health. So unfortunately,
I can speak to it a little bit.
Okay, cool.
I mean, narrative health, or again, or narrative medicine, again, I'm using them synonymously, really refers to the power of storytelling as a therapeutic modality or a therapeutic encounter. Now, again, the part of storytelling is very much part of building a relationship. Really, relationships are based on the stories that we share to one another. So I think there is an intersectionality there. And obviously relationship-centered care, it falls under the umbrella of whole person health or whole person care. So I think this is sort of how I have understood the intersections of these. But narrative again has there are several very prominent individuals who very have shown tremendous value to this form of, how do we use the power of story to really galvanize both behavior change, but also a sense of agency in approaching one's health. So.
Got it. Okay. I like that idea of storytelling. I know for me, I always respond to and remember stories much better than anything else.
And you know what's interesting is when someone's in an early stage of change, or actually they're not even really ready to change. I mean, they may even be in denial that they need to change. And if you're thinking of Prochaska's stages of change, you're in pre-contemplation with me here. But if you, so people are just don't need it, don't want. And then you ask, well, may I tell you a story of someone that was in your similar situation? And again, you're giving autonomy to the patient by asking, may I tell you? And again, I'm going to knock on wood. No one ever says no to that. For some reason, when it's a story about someone, it almost feels like, oh, is it gossipy? Or like, I want to know about somebody else. And they always say yes. And then you tell us a story, which is a clinical case that is, of course, changed. Or in my case, I sometimes tell the story of my own dad because he's given me that right to do so. And then their whole body language changes, and they really, even if they were pre-contemplative before, they're thinking about what you said in that story. And I think it helps to create that alliance.
And I have to say, so I always love panels like this because you learn something new every day. And the funny thing is that as a sociologist, we're used to doing narrative encounters all of the time. And all of our qualitative work is really about storytelling. So it's sort of a full circle moment for me to hear about this as a move out of the social sciences into the health sciences. So fantastic.
Okay, so we've actually come almost to the closing of this really fun discussion, and I've loved being a part of it. And want to thank Primary Care Collaborative again for inviting all of us here today. Just 1 minute or less, I'm going to go, and actually, why don't we go the reverse I went before? I'll start with Dr. Frates, go to Dr. Mehta, and then end with Dr. Hudson. What is the last thought you'd like to leave the audience with today? Oh, wait, you're still muted. Sorry about that.
Sorry, I want to give you something. I'm so excited. I want to give you something. I love to give things away. This is a takeaway, but this is also a free give me, which is a CMECE course, 5.5 credits from the American College of Lifestyle Medicine. It's called the Essentials Bundle. And you'll learn about intro to lifestyle medicine, nutrition for health, nutrition for disease, and I really highly recommend it. It is free right now. So it's my gift to you. But I also want to share, because I get very excited about the science, and this wasn't about the science today, but I want you to know there's significant science backing up these 6 pillars of lifestyle medicine. For example, when you exercise, you release BDNF, brain-derived neurotrophic factor, which helps neurogenesis, you to actually have more brain cells. Your muscles release the myokine irisin, which combines with BDNF and helps increase the size of your hippocampus for your memory. And also irisin is involved in the pancreas to help with beta cell regeneration and survival. And then talking about beta cells in the pancreas leads me to diabetes. And this is the last thing I'll say. We counsel patients with diabetes or prediabetes on their nutrition and their movement. And that's very, very important. I want you to think about all 6 pillars, especially sleep, because we know that when people are sleep deprived, there's evidence that their insulin sensitivity drops. So much so, for example, 5 nights of 4 hours of sleep can drop insulin sensitivity by 24%. So we really want to be thinking comprehensively about the 6 pillars and an intensive lifestyle medicine approach where we could actually start deprescribing medications instead of adding on medications. These are all things you'll learn if and when you decide to get board certified in lifestyle medicine.
Awesome. All right, we're actually at 2 o'clock. So if Dr. Mehta and Dr. Hudson, you just want to say something real quick, I do want to give you the opportunity to just say one last word though, before
No,
we-
I think everything's been well said. I think this, again, we just want to make sure we put attention to this, also a health equity issue. And we didn't get it, but I think that will be a much more important and deeper conversation to be had as a future panel.
Yeah, I would agree. I think we've said a lot during this hour, and if we take away just two things, it's the relationships are key, and this is a team-based sport. So really excited about it. Thank you.
Thank you all so much for being here. I had such a great time with you. And now I'll kick it back over to Anne.
So much excitement from all of the questions that have come into the Q&A, and also everyone who showed up today. So we will be continuing this work with the support of Healing Works Foundation and the Ardmore Health Institute. Look for a survey, look for the link to the webinar when it comes out in the next 48 hours. And also look out for upcoming webinars. Thanks so much for joining us this afternoon. Bye now.